Hello, everyone, and welcome to the Douglas Laboratories educational webinar. My name is Christy Belolovic, and I'll be your moderator for today. Today's title is Thyroiditis, Looking Beyond the Thyroid Gland, presented by Dr. Angela Mazza. And Dr. Mazza is a DO and is the founder and medical director of the Metabolic Center for Wellness in Orlando, Florida. She strives to empower her patients to achieve their unique metabolic health goals through education, lifestyle management, and therapeutic support. She has a significant research background in both basic and clinical realms of blood sugar management and has been the principal investigator and sub-investigator on multiple large-scale therapy and device trials. This expertise has led to multiple first author publications and conference presentations. So we are excited to have Dr. Angela Mazza present today on thyroid, and so I will turn it over to you now.
Thanks so much, Christy. Thanks for everyone for taking time out of your day to join us to talk about the thyroid. This is my disclosure. So the objectives of today's presentation, we're going to take a very brief look at overall thyroid hormone physiology. We'll also review some of the underlying autoimmune processes that are involved in thyroiditis. And we'll do this through a few case studies. We'll also look at some approaches to optimizing thyroid health with a focus on the gut as well as nutrition. So when we think about thyroiditis, thyroiditis is really an inflammation within the thyroid. Just like any itis is an inflammation. One of the most common causes of thyroiditis, however, is Hashimoto thyroiditis. There are other forms that are more self-limited and have different underlying mechanisms, but today we're going to focus on the most common cause of thyroiditis, also known as autoimmune thyroiditis or chronic lymphocytic thyroiditis. Hashimoto thyroiditis is associated with various degrees of underactivity of the thyroid gland, and outside of the United States, it's the most common cause of hypothyroidism. When we go outside of the United States, iodine deficiency tends to be predominant. Hashimoto thyroiditis is really caused by infiltration of the thyroid gland by an overactivity, if you will, of the immune system. And then we see the presence of circulating thyroid autoantibodies. These are the anti-thyroglobulin antibodies. Thyroglobulin is the substance of the thyroid gland, and thyroid peroxidase antibodies. Thyroid peroxidase is an important enzyme in the uptake and incorporation of iodine into a thyroid hormone molecule. As far as diagnosis, the presence of autoantibodies is the most common way to diagnose Hashimoto thyroiditis, but we can also see it in a couple other ways. The other main way is through pathology. So although patients with Hashimoto thyroiditis don't necessarily need biopsies, only if there's a suspicion of a nodule, but when we do biopsies, we do see this lymphocytic infiltration on the path slide. This is a slide of a resected thyroid gland, and you can see these clumps of lymphocytic infiltration. So it's all throughout. So this clear part is colloid, and this is all substance of the thyroid, but you can see right in here the lymphocytic infiltration, and that's pathognomonic for autoimmune thyroiditis and chronic lymphocytic infiltration. But you can also see changes under the ultrasound, and I tend to use ultrasound on a regular basis, mainly because I'm an endocrinologist and I have the ultrasound at my disposal. But I like to look at the thyroid under the ultrasound to give me an idea of kind of what I'm dealing with. So this is kind of a basic outline of what we see under the ultrasound. So I'm going to, since most people don't look at thyroid ultrasounds on a regular basis, I'll kind of go through this with you. This area right here, that's the trachea. So this is the left lobe of the thyroid. This is the right lobe of the thyroid. These are the tissues of the neck, the sternocleidomastoid muscle and the strap muscles. This is the carotid arteries, left and right. And here's the jugular vein on both sides. So those are important landmarks. So this is kind of a basic normal thyroid ultrasound. We see good echogenicity of the thyroid gland, nice and smooth, no nodules, no lumps or bumps. But on with Hashimoto thyroiditis, we actually see under the ultrasound the changes of lymphocytic infiltration. So where we were nice and smooth and had a homogeneous texture, we see a diffusely heterogeneous texture now. So here's the trachea, and here's the left lobe, right lobe, the carotid arteries, and the jugular veins. So we definitely see under ultrasound also changes, which is a kind of a nice and easy way of seeing what we're working with. As far as a brief review of the control of the thyroid gland, thyroid hormone physiology is based upon negative feedback. TRH comes from the hypothalamus to stimulate the anterior pituitary to release TSH. Via a G-coupled reaction at the TSH receptor, we see G-coupled reaction and ultimately production of T4 as well as T3, T3 being the active thyroid hormone. The inverse is true, so ideally when we're making or taking too much T4 or T3, this feeds back to the anterior pituitary to kind of shut down the loop there. As far as the function of the thyroid is to make thyroid hormone. So this involves a number of steps relying upon once iodine presence. Iodine is taken up by the thyroid via a very specific transporter of sodium iodine, and that's taken up by the thyroid globulin. So thyroid globulin serves as a template for combining tyrosine and iodine into actual thyroid hormone. So it's a series of reactions that involves iodine trapping as well as organification, and then the end result is the production of both T4 and T3. Of note, the normal thyroid gland secretes about 100 nanomoles of T4 and really only 5 nanomoles of T3 per day. As far as thyroid hormone metabolism, 5' deodonases are the enzymes that are involved. There are actually 3. Type 1 is the most abundant. And most of the pool of T3 is actually derived from the outer ring of T4 in extra thyroid tissue, so mainly liver, kidney, and skeletal muscle. We see the actual production of T3. There is another hormone another form of T3 that's important to remember, and that's reverse T3. So reverse T3 I like to think of as like the alter ego of free T3. It looks exactly like it, but it's pretty much metabolically inactive. So it's kind of like jamming a key in a lock that's not meant for it. Just jams in there, jams up the receptor, and nothing happens. So it's important to remember the importance of not only T4, T3, and reverse T3. Selenium is actually is abundantly present in the thyroid, and it's important to remember as well. Obviously, it's an essential dietary mineral, but it's part of a number of seleno enzymes, and it's incorporated in all 3 of the deionases. Selenoproteins are involved in cellular antioxidant defense. It's important in glutathione peroxidase. It helps prevent the thyroid from injuring itself through the production of hydrogen peroxide and reactive oxidative species. And it's found in a number of different foods, including Brazil nuts. You can pretty much get the recommended required selenium a day in just a couple of Brazil nuts. Selenium is also important because it's been shown in randomized controlled studies to decrease thyroid peroxidase antibody titers and possibly the symptomatology of hypothyroidism. I think we all know the importance of thyroid hormone because it pretty much affects every part of our body. So on a genomic level, we see effects on tissue growth, brain maturation, oxygen consumption. This contributes to the presence of sodium potassium ATPase in most tissues actually contributes to increase in basal metabolic rate that's important with thyroid hormone. As far as cardiovascular effects, we see positive inotropic as well as chronotropic effects. So in hyperthyroidism, we tend to see increased heart rate and increased contractility. the reverse is true in hypothyroidism. From a sympathetic standpoint, we see an increase in number of beta adrenergic receptors. From a pulmonary standpoint, I don't think many people think about this. Thyroid hormone helps maintain ventilatory responses to low oxygen or high carbon dioxide by the brainstem respiratory center rather. From a hematopoietic standpoint, we see the importance in production of erythropoietin and red blood cell turnover. GI effects are mostly effects on gut motility. Skeletal effects, thyroid hormone affects the bone turnover because bone is in constant state of buildup and breakdown. There are neuromuscular effects. We see definite effects on lipids as well as carbohydrates via hepatic gluconeogenesis and glycogenolysis. And we also see endocrine effects that affect a number of different hormones as well as clearance of hormones. Thyroid is important in especially the clearance of cortisol. It is important to remember that the thyroid is not invincible and is affected by so many different things that are circulating in our environment and what we may be exposed to every day. And this can occur on a number of different levels, whether it's by affecting deiodinase, affecting the thyroid receptor, affecting the TSH receptor. But the end effects can not only show a decreased overall synthesis, but it actually can affect clearance as well as metabolism of itself. So really, how does Hashimoto thyroiditis present? And it's not always as clear as this, although sometimes I think we can all agree. Certain folks walk into the clinic, and I think this is pretty relevant. So in order to try and quantify symptoms is easier said than done. This is from the Colorado Thyroid Disease Prevention Study, and it had a number of different tiers of evaluation. One of them was a thyroid health survey. It was really a one-page questionnaire. It had questions about personal history, family history, demographics. And the most common symptoms that they came up with were significant, were drier skin, poorer memory, slower thinking, weaker muscles, more tired, more muscle cramps, feeling colder, and deep voice. So these are all good things to obviously screen your patients on. But what they came up with was that overtly hypothyroid subjects really reported a greater percent of symptoms than what were considered subclinically hypothyroid. Overt and subclinical all reported significantly more than euthyroid patients. Some symptoms were a little more higher sensitivity, but the absence of a symptom really couldn't rule out thyroid disease. So just having antibodies present, if we checked everybody's antibody titers, whether they had symptoms or not, what is the incidence of developing overt, meaning symptomatically hypothyroidism versus subclinical? And this is from a study of over 82 patients, not a huge study, but it was a long-term prospective study about 9 years. They followed TSH, thyroid hormones, thyroid antibodies on a yearly basis. And what they found was that by the end, 23% versus 58.5% developed symptomatic hypothyroidism with a rate of 4.3% per year if you had positive antibodies versus 2.6% if antibodies were negative. So definitely having antibodies does increase your rate of developing overt hypothyroidism. But again, use your clinical judgment in checking antibody titers. So let's start with the case. So case 1, RR, is a 15-year-old female who presented for consultation with her mother. She was found to have abnormal thyroid function tests and antibodies in 2014. She's originally from Sweden, has been in the States for a few years now. Her mom says that she had a number of severe colds and ear infections as a toddler that were treated pretty effectively with antibiotics. Patient says she has some fatigue, but she also says she has a really busy schedule, has a lot of after-school activities. She says she sometimes has an upset stomach and seems to relate some abdominal bloating that's worse with dairy. Her mom already has her on a mostly gluten-free meal plan, and her mom's really reluctant to put her on prescription medications. So her past medical history is pertinent for what I already mentioned. No surgery. She's on a multivitamin, vitamin D3, as well as a probiotic. She does have a significant history of Hashimoto thyroiditis. Both her mother and sister had it, or has it. She's a high school student, denies tobacco or alcohol. We pretty much talked about her review of systems. Her physical exam, her blood pressure was good pulse, um, a little bit on the low side as far as temperature. She's 5'7", weighs 120 pounds. But what is significant on her physical exam is she has non-tender symmetric thyromegaly. Uh, there was no palpable nodules, no lymphadenopathy, but this was significant. So we did an ultrasound. So she had, so this, so remember, this is the trachea here, left lobe, right lobe. Her goiter was so enlarged it was hard to really keep a good interface between the probe on the right side. But we see this diffuse heterogeneity of the thyroid gland. And what's also interesting is under ultrasound, we can look at vascularity. So just like carotid ultrasound or any other type of ultrasound, we see increased vascularity throughout the thyroid gland itself, which is consistent with thyroiditis, which is an inflammation. So mom brought in some labs she had. So we had some labs available to review. Her TSH was elevated at 4.71. Free T4 was within normal range. She did have elevated TPO as well as thyroglobulin antibody titers. Her vitamin D was less, it was, I would say, suboptimal. So assessment this time, Hashimoto thyroiditis and hypovitaminosis D. So in addition to, we really stressed the gluten-free meal plan at this point and asked her to remove dairy and soy as well. We discussed the importance of sleep because sleep seemed to be an issue. We actually started her on some betaine hydrochlorothiazide, or some betaine with pepsin with her largest meals to toleration. Started L-glutamine for GI integrity. We started some selenium, 200 micrograms daily, which is a pretty standard starting dose, and we bumped up her D3 to 5,000 units a day. So her follow-up at 6 weeks, she says she feels better overall, a lot less GI upset and abdominal bloating. She's trying to keep up with the meal planning, getting adequate sleep as much as a teenager can. On physical exam, she did have a slight decrease in her thyromegaly. So as an endocrinologist, I have to say, just to divert for a second, during my training, Hashimoto thyroiditis has always just been taught as just hypothyroidism. And up until probably within the last few years, as I delved into integrated medicine, I thought the same way too. Put people on thyroid hormone replacement, that's it, end of story. If your numbers are within range, you're good to go. But there really is this autoimmunity component as well. Because autoimmunity really develops over time, and autoimmunity is the key thing that triggers Hashimoto thyroiditis. So preclinical autoimmunity precedes the actual disease in autoimmunity by many years. So picking up those antibodies, is important and can kind of give us a heads up into what may go on in the future. But it's not just genetics. This patient definitely had a genetic component, but there's also we're exposed to different environmental influences, infections, toxic chemicals, dietary components, and stress falls into this as well. But they all kind of coincide into being factors that contribute to autoimmunity. And again, as an endocrinologist, I don't usually quote cardiologists, but I was reading an article from Dr. Mark Houston where he was talking about hypertension and how the blood vessel itself can be exposed to an infinite number of insults. So you name it, it can be insulted by it. But we only can respond in three responses. So we're wired the same ways we were thousands of years ago, and the three finite responses are inflammation, oxidative stress, and autoimmune dysfunction. And I think this really um, is pertinent for Hashimoto thyroiditis as well. Now, going back even further, Hippocrates, the father of modern medicine, was a pretty bright guy. And over 2,000 years ago, he really pointed to the gut as being a component of disease. And we know that not all disease begins in the gut. There obviously are genetic diseases, but there are many chronic metabolic diseases that do as well. And Hashimoto thyroiditis is one of them. So here's the triangle of autoimmune triggers, which I think pulls everything together nicely. So gut dysbiosis, genetic and environmental factors really play major roles in the development of autoimmune disease. We have current studies that show that genetics themselves predispose to about 30% of all autoimmune disease. But that leaves the rest, meaning 70%, are due to environmental factors like those that we mentioned, toxic chemicals, dietary components, gut dysbiosis, as well as infections. So back to our patient. These are her follow-up labs. Her TSH now closer to an optimal range. Her free T4 and free T3 look good. Her antibody titers, although still elevated, were trending down in the right direction. I find that antibody titers tend to change really slowly, so I don't expect them to change overnight. But I do want to make sure that what I'm doing isn't making them worse. So that's kind of how I use the antibody titers. Her reverse T3 looked good. Her vitamin D looked better. We did a celiac diagnostic panel that was negative. So the intestinal barrier is a really key component to immune activation. And again, as an endocrinologist, I never thought I would talk about the gut, but turns out it's super important with thyroid. So the, the, the gastrointestinal epithelium really forms the boundary between the body itself and the external environment. So it's really a kind of one of our first line defenses. So it effectively, provides a semi-permeable barrier that really limits our intake of things that are bad for our system. But at the same time, it has to allow things like nutrition and hydration through. So it is a really kind of delicate balance and maintained by tight junctions. So you can see that if these tight junctions get disrupted, then we are allowing things that really shouldn't have in our system within the system. So that's bacteria, dietary antigens that trigger inflammation. And then we can see our immune system gets geared up, and that's where autoimmune disease can stem from. So this is, I thought, was a pretty cool picture, and it's ultrasound changes in the enterocytes of someone with patients with Hashimoto thyroiditis. So basically, in this study, they took biopsy sections from distal portions of the duodenum. So A is considered the healthy control, and B is the person with Hashimoto thyroiditis. So they looked at a number of different parameters, and including the space between the microvilli, these are the microvilli, the mean height of the microvilli, and the thickness of the microvilli. And between looking at the two, there definitely was a suggested alterations in the morphology of the enterocytes. And you can even see that on the cross-section, where these are nice and neat and close together, and we see somewhat abnormal-looking microvilli in the Hashimoto thyroiditis. There definitely, obviously, is a link between thyroid and gut, just on a purely functional standpoint. So heartburn, dysphagia can be due to actual esophageal motility issues. There can be delayed gastric emptying that can cause nausea, dyspepsia, even vomiting at times. Constipation can be a result of decreased motility. We can see reduced acid production or hypochlorhydria due to an underlying autoimmune gastritis. Usually, some of these functional symptoms improve with really proper support of the thyroid. So that in turn bringing the thyroid in balance. Overall, the GI manifestations from a functional standpoint are usually due to motility effects. So hypochlorhydria really can be caused by lots of different things. And how many of our patients are on proton pump inhibitors um, or things that affect the acid level of the gut? Aging can affect acid levels, stress, fasting, viral and bacterial infections. Obviously, since we're talking about thyroid, hypothyroidism can do it. Plus, autoimmune conditions can cause hypochlorhydria. So support can include betaine, digestive enzymes, stress management. I never underestimate the benefit of stress management. So dysbiosis, kind of getting back to that autoimmune triangle, is really the state of imbalanced microbiota of ecology that contributes in turn to disease. So it's the gut microbial ecosystem itself. So our ecosystem and our gut actually outnumber our own human cells by about 10 to 1. It's affected by so many different things. So like I mentioned, genetics play a huge part. Diet plays a huge part. Even how we're born plays a huge part. So we see differences in the gut microbiome in someone who was born vaginally versus C-section, vaccinations, antibiotic use, overall hygiene. So this can affect the difference between healthy regulatory T cells or dysfunctional response of our immune system. So I like to think of the intestinal microbiota as an endocrine network in and of itself. So because the gut microbiota play an important metabolic role in a lot of disease states. The bacteria itself, plays a number of factors as well as just basic things like breakdown of dietary fiber, fermentation, vitamin absorption, mucus production. So these are considered metabolic functions of bacteria. So when that's off, it affects the whole system. The gut microbiota actually produce biologically active compounds that, like hormones, they travel to all different parts of our body. They carry signals. So like I mentioned, the gut is the first and the widest area of bacteria access. So, and it really is where the highest concentration of T cells in the human body lies. So 70% of our immune system lies in our gut. This contains more than 1,000 species, encoding more than 150 times more genes that are even present in our own human genome. So it is super, super important. There is studies to suggest that does the gut microbiota itself trigger Hashimoto thyroiditis, or does the microbiota composition affect thyroid homeostasis? And I think that it does definitely play a part. And I think we're only starting to realize the effects that it plays. So if you notice, I did put our patient on a probiotic. Which probiotic is always a question because, again, we are just starting to understand the realm of probiotics. But probiotics in general help improve overall mucosal barrier function, that epithelial tight junction. Help suppress some of the invasion of pathogens getting through those tight junctions. They help upregulate beneficial IgA to support our overall immune response. Obviously, they help with diarrhea as a result of antibiotics and help produce butyrate, which helps overall with gastrointestinal health. So is there a link between celiac disease and thyroiditis? So because we really stress the importance of a gluten-free, soy-free, dairy-free, but are we doing it gluten-free for this patient because of her risk for celiac disease? Well, no, not necessarily, but there is a prevalence of Hashimoto thyroiditis in the setting of celiac disease, and it's estimated to be anywhere between 1 and 20%. So we don't really have good numbers on that, but there is a correlation. lots of symptoms overlap between Hashimoto thyroiditis and celiac. So, I mean, how much of an overlap is weight changes, joint and bone pain, fatigue, hair loss. These are definitely symptoms that go along with celiac or Hashimoto. And they both have environmental, pathological, immunogenic, hormonal, and genetic aspects. This study suggests that maybe selenium plays a part. And because, as I mentioned, selenium is really important for the thyroid. The thyroid itself is really sensitive to selenium deficiency because those selenoproteins are important for thyroid hormone production. Um, in fact, some selenoproteins like glutathione peroxidase actually are involved in inhibiting apoptosis. So it may lead to suggest that selenium deficiency and malabsorption in celiac disease may be a factor directly linking thyroid as well as intestinal damage. And when it comes to celiac patients and patients with hypothyroidism who have both, it also is important to remember that absorption of any sort of thyroid hormone replacement can be affected due to the reduced intestinal surface available. So if you have someone you keep going up and up on their thyroid hormone replacement, you're just not getting where you need to be, think about maybe a kind of an underlying celiac issue affecting their absorption. So I love this quote by Dr. Tom O'Brien, where he says, "Just stop throwing gasoline on the fire." So, and that couldn't be more true. So what about a patient who we know doesn't have celiac disease, we don't know doesn't have non-celiac gluten sensitivity? Why would we still put them on a gluten-free meal plan, at least for a short term? Well, just this fact in general. So we don't want to put fuel on the fire because we know that everybody actually shows changes in intestinal permeability to wheat exposure. And it's really not just folks with celiac or non-celiac gluten. It's just that folks that are overall healthy just are able to heal faster. Because say we eat something with wheat, we do have intestinal changes, but then we heal and we kind of start from square one. In this study, they actually did show this. So gliadin is a component of gluten. It's really the main glycoprotein in glutinous foods. So they showed that intestinal exposure to gliadin levels affects intestinal permeability, increases intestinal permeability. So they did this by taking 4 groups. So they had folks with celiac and active disease. They had folks with celiac in remission. They had non-celiac patients with gluten sensitivity, and then they had their healthy controls. So they gave all groups gliadin exposure. Obviously, patients with gluten sensitivity and active celiac disease showed greater increase in intestinal permeability, but they saw increased intestinal permeability in all groups. So I think that this is cause to really say, all right, our patients with autoimmune thyroid disease, let's at least put them on a short course of a gluten-free meal plan, just at least in the beginning, until we can get some things under control. Okay, let's move on to our second case. So CB is a 19-year-old female who presents for consultation regarding newly diagnosed Hashimoto thyroiditis. She also is here with her mom. She has complaints of fatigue, cold intolerance, constipation, abdominal bloating, some mood changes, irregular cycles for about the past 12 to 14 months. So she was started on 2 different brands of levothyroxine and noticed that the anxiety that she had been having before actually was getting worse. She was having palpitations and feeling horrible in general. She has a past medical history of migraine headaches and scoliosis. Surgeries include tonsillectomy and spinal correction surgery for the scoliosis. Current medications, she's on an oral contraceptive as well as levothyroxine. She has a family history of maternal grandmother with hypothyroidism. She actually just completed her first year away as a college student. She denies any alcohol or tobacco. And review assistance is pertinent for the HPI. One thing that also came out in her past medical history is she had a very stressful year on top of college. Her mom was being treated for ovarian cancer, so it was a rough year for her. As far as physical exam, vitals, blood pressure was stable. Um, her height, 5'1.5" weighing 103 pounds. As far as physical exam, it was grossly unremarkable. She did show some dry patches on her upper arms and elbows, as well as her hairline. Okay, so she also had some labs to go through when we first met. Her TSH was elevated at 5.02. Free T3 was low. Her antibody titers were slightly elevated. I mean, they weren't as high as the first case, but she did have positive antibodies, and her vitamin D was low at 19. So initial assessment, again, Hashimoto's thyroiditis and hypovitaminosis D. So instead of the levothyroxine, we changed her desiccated thyroid hormone. Not everybody tolerates synthetic thyroid hormone, obviously. We started on vitamin D3, 5,000 units a day. We started a gluten-free, soy-free meal plan. Started on probiotic, and really, again, counseled on sleep hygiene. So her follow-up at 4 weeks, she was feeling better, but still with some fatigue and constipation, no palpitations, and she admitted to some lapses in meal planning. So here were her labs at follow-up. Her TSH was not optimal with a TSH of 4. Free T4 and free T3 looked pretty good. Vitamin D was improved. We did some urinary testing for selenium, iodine. I like to at least get a baseline on iodine and selenium. We also did a 4-point salivary cortisol test that was, I don't have the curve for you, but it was suboptimal, and we did a celiac panel that was negative. So assessment at that time was Hashimoto's thyroiditis, hypovitaminosis D, as well as hypoadrenalism or HPA, axis dysfunction. And at that point, we adjusted her desiccated thyroid hormone. I added vitamin K2, divided to the D3 for increased benefit. I added an adaptogen blend for adrenal support, considering her hypoadrenalism. We started a glutamine with aloe vera for GI integrity. Her probiotic continued. Really encouraged the gluten-free meal plan, although we also stress stress management. All right. So at 6 weeks, she was doing much better. Fatigue's improved, no migraines. Her constipation, abdominal bloating resolved, and we continued her current therapy until she followed up. She was going to follow up on her break from school. So her follow-up labs on her break, TSH 1.98, free T4 was good, free T3 was good, reverse T3 looked pretty good, vitamin D looks great, and then her antibody titers are now within normal range. So these are the components of the GI support, or the GI integrity that I use. It's a combination of L-glutamine, which is really great for the gut. Aloe vera also helps protect against reactive oxygen metabolites. So this is a good blend of components. So other tools to help support gut integrity, obviously probiotics, elimination diets, or avoiding foods that provoke issues. Glutamine, aloe vera, vitamin A, zinc, quercetin is, fiber, again, as well as stress reduction. So obviously vitamin D is super important, and we can't always get vitamin D from donuts, but the more and more I check for it, obviously I think anyone listening would agree that it's important and it's out there. And vitamin D is super important overall. I mean, it is, after all, a hormone. It's not just important for bones. But since we're talking about Hashimoto's thyroiditis, vitamin D is really important just with Hashimoto's thyroiditis. So I have a few studies here that I think are pretty send home the point. So this first study was a study of, they had a few different groups. Group 1 were euthyroid patients with Hashimoto thyroiditis on stable levothyroxine. Another group were also age and sex matched, BMI matched, newly diagnosed Hashimoto thyroiditis, as well as a group of healthy controls. And really what they found here was the lowest vitamin D levels correlated with antibody titers. So the takeaway point from this study was gave the potential role of vitamin D in the development of Hashimoto thyroiditis and overall progression to hypothyroidism, which I think is pretty significant. Here's another study. 75 patients with Hashimoto thyroiditis versus 43 healthy controls. They found that persons with Hashimoto thyroiditis, one, had significantly lower vitamin D levels. They were able to replace vitamin D and see a decrease in thyroid autoantibodies. So the takeaway point from here was vitamin D deficiency very frequent with Hashimoto thyroiditis, and perhaps patients with the condition, if we give them vitamin D, slows down the overall development. They looked at HDL in the study too, so they also concluded that perhaps it affects cardiovascular risk too. And finally, this study was from sunny Crete, Greece. So they had over 200 patients with Hashimoto thyroiditis. They treated them with vitamin D3 for 4 months, and the treatment group showed significant decrease in anti-TPO levels. So again, this suggests that vitamin D deficiency may be related overall to the pathogenesis of Hashimoto thyroiditis, and that supplementing it could contribute to the overall treatment. So vitamin D is important. So we did use a phytoadaptogenic adrenal support with this patient, which is a combination of herbals. Length of time for treatment, I usually treat for about at least 6 to 12 months, depending upon the patient. And this is our last case. So case 3, DZ is a 36-year-old male he was actually referred for abnormal thyroid function test and a biopsy. So he says he was having some neck symptoms as far as discomfort, tremors, weakness, fatigue, wasn't sleeping great, joint pains, migraines, palpitations, some shortness of breath with exertion. Started about 2 months prior to his presentation here in the office. He says he's starting to feel better though. So his past medical history is pretty much what I stated. No surgeries, no medications, family history of colon cancer, and maternal grandmother with hypothyroidism. So he is a college professor, actually under a lot of stress, denies any tobacco or alcohol. As far as physical exam, these are his vitals. His weight's 149. He's 5'6" tall. On exam, pretty unremarkable. So I had some labs and imaging for review. So on the ultrasound, they reported some ill-defined nodules on the right, measuring about 1.6, some mild thyromegaly. Just as an aside, as far as biopsy, we generally consider biopsy in nodules that are bigger than a centimeter. So that was the main reason why he was sent over. His TSH was low at 0.02 on these initial labs. Free T4 looked good, and his free T3 looked good. So I actually don't always trust ultrasound reports that come through, so I oftentimes do my own. So actually on his ultrasound, again, here's the trachea, left lobe of the thyroid, right lobe of the thyroid. In this right area here, he does show some heterogeneous changes, but this when I looked at it in all three, I don't have the imaging in the other planes, but this actually wasn't a nodule. It just really was some diffuse heterogeneity that showed some increased vascularity. So his TSH was elevated at this point at 7.28. Remember, he was 0.02 before. His free T4, free T3 were okay within normal range. His his antibody titers were elevated with a TPO of 30 and a TG antibody of 52. I did a thyroid stimulated immunoglobulin. So TSI, or this thyroid stimulating immunoglobulin, is pathognomonic for Graves' disease, which is autoimmune hyperthyroidism. We did a 4-point salivary cortisol that was elevated. So at this point, his assessment was hashitoxicosis, or which at this point he was hashitoxic, but now he's Hashimoto thyroiditis. Care plan, we started a gluten-free, soy-free meal plan. We started a probiotic, really counseled on stress management, and started a calming adaptogen blend. So these are the components of the stress relaxant support. Has a casein, which is a polypeptide 10-chain amino acid. This is okay for even people with sensitivities to cow's milk. It helps decrease glucocorticoid secretions, helps rebalance the HPA, or hypothalamic pituitary adrenal axis. L-theanine, found in green tea, helps relax without causing drowsiness, and has some vitamin D too. So his follow-up at 8 weeks, his TSH was 1.29, free T4, free T3 looked good, reverse T3 looked good, antibody titers were now within range. So I did a follow-up just out of curiosity. I don't always do follow-up ultrasounds in this case, but I wanted to make sure that indeed there was not a nodule there. And you can see this area of heterogeneous tissue is now nice and homogeneous, rather, just like the rest of the gland. So I think I've kind of stressed the stress component of Hashimoto thyroiditis, and this picture reminds me of, if anybody's read the book, Why Zebras Don't Get Ulcers, but I think the zebra is a little stressed, but cortisol and stress is super important because it really affects our entire system, because just like I mentioned about we have an infinite number of insults and only a few number of responses. Same thing is true for cortisol. Important to remember that cortisol is our stress hormone. It can act in a catabolic way. And when it comes to the gut, it can decrease these tight junctions, leading to increased intestinal permeability. It really affects the balance between our immune system, can increase histamine load, and that can in turn increase food sensitivities and food intolerances. And over time, I didn't mention too much, but there is something called molecular mimicry, which kind of is one of the underlying immune issues with immune dysfunction, and cortisol can increase this. This is a study. So too much cortisol isn't good. Not enough cortisol isn't good. A healthy balance is probably what we strive for, not always attainable. But in this study, this was over 300 persons. They looked at antibody titers, both TG and TPO, and they found that basal cortisol levels were significantly lower in persons with thyroid antibodies. So this is kind of an inverse correlation. So there's not a whole lot more information from that, but there is definitely a correlation there. And then finally, stress-mediated activation, of cortisol can really throw off our immune system, as we know, and in turn lead to autoimmune thyroid disease activation. So take-home points at this point is obviously thyroid hormone replacement is not the only treatment for Hashimoto thyroiditis, although it is important when needed. Hashimoto thyroiditis is an autoimmune disease that needs attention to really look at the underlying causes of immune dysfunction. Important to look to the gut for dysbiosis. Look to support intestinal permeability. Address the adrenals as well as vitamin D status. And then consider any additional nutritional supplementation based upon the patient. So that concludes my presentation, and I'm not sure if you have any time for questions or.
Yes, thank you so much, Dr. Mazza. That was wonderful information. I know I learned a lot of new things and actually had some of my questions answered in your presentation. If there are any questions, please type them into the chat box on your screen. And one thing I wanted to cover real quick is, or more to clarify, is all hypothyroidism autoimmune, or are there other types of, clinically diagnosed hypothyroidism?
Right. No. Good question. So hypothyroidism is really just any decrease or lack of thyroid hormone. So, iodine deficiency definitely plays a part, and that would not fall into autoimmune thyroid disease necessarily. Obviously, someone who had their thyroid taken out, that is hypothyroidism. That's not autoimmune related. And now, with the emergence of all these endocrine disruptors, they may disrupt and cause hypothyroidism that is outside of an autoimmune spectrum. So that's why it's helpful to kind of have other modalities and labs to really help clarify.
Correct. I know some traditional doctors don't always test the antibodies though, and I think that's definitely an important factor to make sure somebody requests from their practitioner.
Yeah, I get a lot of patients who they've done some reading on their own and they really want some further evaluation to know what they're dealing with, rather than your levels are normal, so take your levothyroxine.
Yeah, exactly. And I know that the standard back, a while ago was to do a thyroidectomy. I don't think that's quite the case anymore, but I know even my mom and my grandma had that happen to them, and
really,
who knows if it was Hashimoto's or not, because, that was kind of the quick answer back in the day.
And surprisingly, I still kind of get these questions from patients where they've been sent over by their primary care doctor, or they've actually sometimes even seen a surgeon already, where they think that the Hashimoto thyroiditis is going to be fixed by taking their thyroid out, whereas that's really not going to definitely fix anything. Then you're definitely going to have to be on thyroid hormone for the rest of your life, and you still have the autoimmune issues to deal with.
Correct. Yes,
absolutely.
Scary. I know, for sure. Another question that came in was to discuss a soy-free diet. Do you have any recommendations on that? I know soy can definitely be a culprit in the gut and causing an immune response. So have you ever tried any patients on a soy-free diet?
Yes, definitely. I really stress the importance of anyone on thyroid hormone to stay away from soy if they can, because the structure of soy is such that it can actually affect circulating thyroid hormone and affect thyroid clearance. So just from a metabolism standpoint, I say, don't drink soy milk. If you have edamame every now and then, it's not like the end of the world. But I don't recommend, having a consistent diet of soy whatsoever. So I don't have a specific soy diet plan. I kind of just go through foods that have soy in them. I really stress the importance of looking at labels and just trying to stay away from it, from an overall thyroid standpoint.
Okay, that is good to know. And just a little bit ago, you said that some hypothyroidism can be related to iodine deficiency. I know people can get their iodine levels checked. And then just remind me on intake of iodine for Hashimoto's. Is that an important factor?
So that's a good question, because there's a couple different schools of thought. Unless iodine levels are really low, and I tend to rely more upon a urinary iodine than a serum, just because I feel like the assays are because I'm usually dealing with insurance laboratories, and their assays are all over the place when it comes to serum levels, so I usually stick with the urine. Unless the urinary iodine is very low, I don't recommend any extra iodine, only because we're dealing with thyroid hormone in specific levels, and it actually can can affect overall function of the thyroid. So too much or too little thyroid can actually cause a problem, because I've had patients start iodine supplementation and actually kind of puts them in the hyperthyroid range, and it's difficult to get back under control. If someone is extremely low, I go very gradually. I can't say that on a regular basis I use iodine, just because we're dealing with balancing so many things at once. If it's Hashimoto and iodine, I try not to.
Okay, that's good to know. And there are
if it's not Hashimoto, then yeah, I will give iodine replacement.
Okay. Yeah, and I know you have to be careful. There are some iodine supplements on the market that are very, very high dose, and that's not always the answer. So I think starting low and working up, like you said, is the best option.
Yes.
All right. Well, that's all the questions that came in, so I do want to thank you for your time and education today, and I want to thank all of our listeners. A copy of this webinar recording will be posted at the Douglas Laboratories website under the Education tab, so please visit that to review the information on the slides. And thank you all for attending, and I hope you have a wonderful afternoon.